Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. We're live. Hey, what's up, guys?
Hello.
Say right.
Oopsie, there's Kieran the Magnificent.
All right. I can't do it. Oh, yeah, wait, back up a little bit.
And then I forgot.
Can we start all of our episodes with our GCS now? What's up? Welcome to the podcast. I am Katie Cleaver.
And I'm Melissa Stafford.
And I'm Elizabeth Mills.
And I'm Kieran McMahon.
Thank you guys for joining us. Today, we're going to talk organ procurement. So if you haven't already listened to the brain death episode, please go back and do that. That episode really flows into this one. So organ procurement is something that is done typically in like the ICU. It is in the ICU setting. It might be in a cardiac or a neuro ICU setting, but it's essentially procuring organs from someone who has passed away and giving them to people who need them. I mean, that's about the basic definition, I guess, right?
Yeah.
But there's a lot that goes into it.
There really is.
And one of the first things I want to say is don't say harvesting.
No, don't.
That is a bad no term. Organ procurement. And what's the other word? There's another word that you can use that's okay. But it's you definitely like saying we're going to harvest or do it. That's
Yeah, we're not harvesting a crop.
Right. Right. There's not the thing
This
to
is
say.
not a dystopian future.
Right. It is not. So, in our last episode, we had talked about when you have a patient, when you're determining brain death, and you notice, okay, this is a big deal. This is a non-survivable injury or whatever, and you hit your triggers. We talked a little bit about notifying the organ procurement organization, which is frequently abbreviated as the OPO. Can you guys talk about organ procurement organizations briefly? Like, what's it like working with them? What are their goals? What can't they do, and can't they do?
There's different organizations all over the country. There may be multiple in one state, but their job is essentially to help once they've gotten a referral about a patient. Essentially, they're going to start delving into the patient's chart, get the patient's history, get their information.
Not talking to the patient's family yet.
They are not talking to no, they don't. They do not. The actual coordinator does not talk to the family, but they are kind of looking to see what if patients are potential organ donors, what they could be, what they could donate.
Because that's different, right? Someone may have, maybe you have a 20-year-old that had an overdose and they have a congenital heart issue, but maybe their lungs are fine, or maybe they're, so it's not everybody can donate the same thing.
Correct.
So it's important to identify that.
There's certain things like past medical history plays into what is potential donation. Lab work plays into it. Age plays into it. To be a heart donor, those are young donors. Those aren't, older population. Their age plays into organ donation in general, but the important thing is to notify the agency early on in the process. The earlier that you notify them, kind of the smoother things go along, if it becomes appropriate. So there are many times that we may make a referral that they kind of drop off because it doesn't become appropriate to see it through. So we have somebody that comes in with a devastating subarachnoid hemorrhage. I always go to neuro, and we're not expecting things to go well, but surprised, some patients do, because that's our end goal, right, is to help the patient get better. So when it becomes clear that they're not going to progress to brain death, then they kind of step away. So just because you make a referral does not mean that the patient is going to end up being an organ donor for various reasons.
Yeah, so that's just because you're calling the organ procurement organization doesn't mean that, now they have to donate their organs.
No.
And
they don't dictate care either. So
Right.
them being aware of the patient doesn't impact what you're doing for the patient
At
as
that
a nurse.
moment.
Yes, and that's really important. And it's also something where you don't want to notify the family that you're calling these.
No.
Because you don't want anyone to have that perception that you want their organs or something like that.
Because it isn't a very sensitive, ethical
Yes.
thing. I don't know what an issue.
No, it's
not an
yeah.
issue, but
Situation.
yeah, and with different cultures,
Yeah.
there
and-
is a stigma.
And
with
it's
it.
and the important thing is for someone to donate their organs successfully. This process has to be started early. So they want to start it early, but you don't want to tell the family because you don't want that immediately. They will be notified. They will
Right.
be active and part of this process. But with this referral, immediate, just admitted to the hospital, we're identifying that they're a GCS of less than 5, and they've on event had a devastating injury, whatever. So we need to start that process early so that they can do their screenings that they need to. We mentioned this in the last episode, but it's also a legal thing.
Yeah.
We cannot deny a patient or family the opportunity to donate organs. And that can be tissue and eye. That can be that they have to have that opportunity. And if your facility denies that, then you can be subject to significant fines and that's a big issue. So you always have to have that, option.
Mm-hmm.
And yeah.
Yeah, and know that it's time sensitive. I know we talked about in the last episode, but for us in critical care, when they come in with a trigger of a GCS less than 5 on a ventilator, by law, we're required to notify them within an hour. Now, if I'm trying to take care of the patient, I'm probably not going to be the one that calls them. I'm going to delegate that to one of my team members.
Teamwork, baby.
But, it is something that we are supposed to notify them promptly because things can change. I mean, they can progress very, very rapidly downhill. So they need to be aware of it early on. So it is a big deal for you to be aware of and to be thinking about that and know your facility's rules and regulations in regarding to notification of the OPO.
Yes, know your policies. One of the things we had mentioned earlier, and thankfully, I'm just thankful that we have this in our electronic medical record where if you put in a GCS less than 5, you get an automatic trigger.
Yeah.
You maybe it's not appropriate to call them. I don't know why I can't really.
Medications on board,
Yes.
Things like that.
Things like that, but it gives you that trigger, that reminder, which is so helpful. So let's say, okay, anything else about that?
No, I think GCS less than 5, a patient with an imminent death. I think that's one of the I'll call, like, if I know a family is wanting to withdraw care on a patient, I will call them ahead of time to say this. I have an imminent death. Here's the information. Because they could potentially be a donor after cardiac death, which we'll get into. But those triggers, or the patient's made a DNR now. Maybe the referral team has been following the patient, and the family's decided to make the patient a DNR. So, but the big trigger is a GCS less than 5.
Okay, so let's say we've got our patient. They have had. They went through our last episode where we had their brain death testing showed that they are brain dead. Okay. The organ procurement organization has been following kind of from the back, from like loosely. Okay. Now what?
Well, last episode you defined what GCS was, and then I forgot.
So GCS is the Glasgow Coma scale.
Excellent.
And of course, we talk also in the last episode about how we hate the word coma.
Yeah.
It's not in the medical system anymore. Now it's in our GCS. I didn't even think about that. But it's a way of like quantifying how out of it they are.
What level of unresponsiveness we're dealing with.
Yes, that's a better way of saying that. So that's a big trigger.
So the highest is 15, and that's a patient
That's
like
us right now.
I might be a 14 because I'm drowsy, but
You're talking. You're 15. You're good.
Can we
yeah,
start?
eye-opening.
He's just on a lot of caffeine.
Can we start all of our episodes with our GCS now? Hi.
Well, I hope they're all 15.
We're hoping for 13 to 15, right?
But the higher the number, obviously, the more awake and responsive a patient is.
And so the highest is 15. The lowest is 3.
A dead body is 3.
That's correct.
That seems
can never
offset
be
by
zero.
a little bit.
Nobody can have a GCS of 2.
Yes.
GCS is made up of eye, verbal, and motor response. So based on if your eyes open at all, we'll get you the eye opening score. Based on if you can talk or make sounds, we'll get you the verbal score. And then what kind of movement or lack thereof you have gets the motor score.
Yeah, so no movement, no eye movement, and no
eye opening, no speech, and no movement.
gets you the 3.
You still get a point.
You still get a point.
Just for signing your name.
Just that attendance.
Just for being there.
Just for, yeah.
3 attendance points. Okay. So we've defined GCFs. Okay,
Thanks for
we've got
asking that.
Yes,
Yeah.
that's good. I'm really glad you asked for that clarification. So we've got that patient that's got the GCS of 3. Apnea test is negative, or I guess is positive, which is a negative
I
thing.
never say apnea negative or positive. I always just say apnea test confirms brain death.
Okay, yes,
Or not, because it's too confusing.
That's too confusing. So we have, and one thing I wanted to say, and I meant to say it in the last episode, was patients can be so close to brain dead, but not.
Yeah.
I'm going to actually talk about that in a minute.
Okay,
Yeah.
so I will hang. Okay, so we've got the patient that we're here to this point where we have a brain dead patient who's been declared, and the organ procurement team has been following. Now what?
So we have to talk about consent.
Oh yes,
So
consent.
There's a couple, 3 different ways that I can think of offhand, and I hope I'm not leaving anything out. But there is something called first-person consent, which varies among states. But I'll say in the state of North Carolina, if I am an organ donor, don't anybody come and try and attack me. But on my driver's license, I am an organ donor, and that's considered North Carolina first-person consent. So if I, heaven forbid, I'm in some sort of accident and I become brain dead, then I have already given consent myself to be an organ donor. So that kind of takes the pressure off my family to have to make that decision.
Mm-hmm.
This is a big decision to make. There's also a donor card that many OPOs have, and I honestly remember getting one in college. I don't remember under what circumstance it was. It might have been a lecture on organ donation, but you can go to the website and oftentimes print out a card and sign it that you want to be an organ donor. I can't even really honestly think in 16 years of personally ever seeing that, but it's out there. And then probably the most common way is family consent. So, or I should say next of kin consent. So whether that be healthcare power of attorney or spouse or children or whatever the parents, whatever the case may be. Once the patient is pronounced brain dead and the can we just say OPO?
Yes, OPO, Organ Procurement Organization.
Yes, once the OPO determines the patient is a potential donor, then they would approach the family for consent. And then during that, it's an incredibly long questionnaire that they have to get into. It talks about things like potential for IV drug use, in addition to all their past medical history and social histories and things like that can impact disease risks, if that makes sense. But they often, I know in my experience, it's been even in the population where the patient had the organ donor designation on their driver's license, they still approach the family and they still say, that's something to the effect of your loved one indicated that under the circumstance they would like to be an organ donor, and approach the family that way. Mm-hmm. Now, I can also say that it's been my experience that even in a situation where there has been that designation on the driver's license and there was some sort of family disconnect with that and they were very adamant against it, whether it be for religious reasons, cultural reasons, what have you, that I have seen them say, okay, I want to be respectful of that and then kind of back away. But the consent process through the family is what are you okay with us potentially trying to evaluate? Heart, some cultures don't want heart. You can have everything else, but not the heart. Can we try the heart? Can we try the lungs? Can we try the liver? Can we try the kidneys? Can we try eyes, tissue, bone? I mean, and bone is included in tissue, but there's lots of different things that they can say, yes, you can evaluate that for placement, or no, you can't. So they try to be very respectful during that, but they have to get consent.
And remember, that's a really emotional time. They just
Yes,
found
it
out their
is.
loved one died moments ago.
And
Not moments.
usually it is a family coordinator. It's not
us as the caretaker.
It's not us as the care team. So it's not the nurse and the physician saying, okay, we have, your patient, this loved one has been confirmed brain dead. Can we donate organs? I mean, it is a very sensitive approach.
Yeah, because how
It has to be.
much of a conflict is that?
Oh,
right?
it totally is.
Would that be if it was like, okay, they're dead, let's take their organs?
And I've seen cases where a physician has said, okay, this patient is an organ donor, and
It's not received well.
it's not received well. And that patient who was an organ donor on their license ended up not being, because it created a conflict with the family.
Yeah, so it must be brought up.
So pay attention to your policy where you work and know who is allowed to approach the family regarding this subject.
Yes, it's such a big deal.
It really is.
Such a big
And if
deal,
the
guys.
family is asking information, that's one thing.
Right.
But we, as the care providers, can't initiate that at my facility. I don't know if
Right.
that's true across the board, but
It should be.
no,
No,
I
it's
personally
most,
wouldn't
I
want
think.
to be, but
Right.
because I don't want to create that conflict. I
Right.
don't want them to think that I am not going to do something that I need to do to try and save their loved one.
Right. Like, right.
So,
So let's say we've gotten to that point. Did you guys want to say anything else with that?
no.
Okay, so we've gotten to the point where, let's say the family's been approached. Maybe there was first person consent. Family's on board. Now what?
A whole lot of activity, lab work.
This patient becomes like almost a 2 nurse to 1 patient ratio for the first couple of hours. It is a lot of stuff.
It is a lot of stuff.
Tell me the stuffs.
So central line placement, if they don't already have an arterial line placement, you are drawing a plethora of labs.
Yes.
And why?
Well, there's lots of different reasons. So we will have had some lab work on the hospital end anyway. Some things are tissue markers, blood type, tissue markers, things like that, that they use our information from our facility to confirm that with an outside lab as well. So if I'm A positive, or if the hospital says I'm A positive, they send my blood to a different lab that confirms A positive.
Got it.
And then there's lots of different tissue markers that they look at, so they can check antibodies and lots of things. Electrolytes. I want to say there's 22 tubes of blood that I draw with the first blood draw. I think it's 22.
So hence why an art line is so helpful.
Or central line, yeah.
Central, yes.
Either one.
And it
I
seems
like
like a
art
lot of
line
blood.
better.
You are taking quite a bit of blood.
Yeah.
And sometimes if families are present, I'll say I'm going to draw a lot of blood work.
Yeah.
Because the families can still stay.
Yeah, they absolutely can.
Oh yeah, wait, back up a little bit. I guess I'm talking about the technicalness, but let's say the patient's been declared dead,
And
Yes.
they've consented to organ donation.
and they've consented to organ donation. The patient's still in the bed on a ventilator with a heartbeat
And
and a blood pressure.
yeah.
And so that's kind of challenging for family to know that they're dead. But at that point, you as the nurse, your documentation changes a lot, doesn't it?
It does. So my focus is no longer about, sounds so crude. It's no longer about saving that patient's life, right? Because they've been pronounced dead.
Right.
My focus at that point changes to organ perfusion and
Mm-hmm.
maintaining that organ perfusion. So everything that I do to this patient now is not curative. I'm not trying to cure this patient. It really is just about maintaining perfusion to all those organs.
So we went from life support to
Yes.
organ support
Right.
in that moment.
Right.
So it's really important to know that, like, the ventilator is supporting their organs. It is life is not in there, as awful as that sounds.
Right.
But so from the nursing perspective, you're not charting care plans.
No, there's no care plans. There's there's not education forms that you have to fill out, those kinds of things. But what there is a whole lot of documentation in regard to vital signs and I's and O's.
Right.
So it's really labor intensive as far as making sure that you're following your heart rate, your blood pressure, changes in that, your urine output
Blood sugar.
becomes incredibly important.
Oh, yes.
Sodium.
Blood
And
sugar, temperature.
it's important because we're going through this period of time where the body, the brain is dead.
Not regulating anything.
Yeah.
Right. So we're going to have some challenges.
Mhm.
Yeah.
So what are some of the routine things? So we've drawn labs, but we're anticipating issues. What kind of issues are we anticipating?
At the very beginning, we essentially give them medications to throw them into a thyroid storm. So oftentimes when patients are in the process of being declared brain dead, they're hypotensive.
Mm-hmm.
And so we probably already have them on medications to keep their blood pressures up.
Mhm.
I mean, I have had some that maintain it on their own, but it's very common that they're on some sort of pressor. We give them medications to throw them into a thyroid storm, which then in turn makes it possible for us to get them off of vasopressors.
Mhm.
It raises their blood pressure. So we're essentially tricking the body into thinking the brain is still supplying all the hormones that it normally does.
Mm-hmm.
So we give levothyroxine, we give insulin, we give Narcan. And Narcan, people think of Narcan to wake a patient up. That's not why we're giving Narcan. We give Narcan to try and to stave away neurogenic pulmonary edema. So we start steroids. I'm trying to think of all the things right off the top of my head. I mean, there's a long list of medications that we will get started at the beginning, and they'll be ongoing. There's some things that we only give at the beginning, and then there are other things that we give periodically throughout the procurement process. And then the other thing is then we have to look at, not we, but we are guided. Care, I should probably say this. The moment the patient is pronounced brain dead, care is then dictated by the organ procurement agency, the OPO. So remember before I said we notify the OPO, but they don't dictate care. Once they become brain dead and we have consent, they manage the care.
They're in charge.
Yes.
Mm-hmm.
So every medication that we give or don't give, every test that we do or don't do, that's all dictated by the OPO.
Yeah, because the focus is so different.
It is.
And I remember being involved with that the first time. I was like, oh wait, there's this documentation, or if we're gonna do this, why don't we do this? Like, no, Katie, that's not the goal.
Yeah.
The goal isn't to wean them off of this or do this. It's to get them to the OR, or it's to keep their
keep them
organs perfused long enough to find matches,
Yes.
and then get them to the OR at whatever point that is. So that was
Right.
so weird. And also, and keep in mind, guys, we're saying all this from our experience. This all changes, can have different changes and will look different based on your state and your facility and all that. So this is all general, obviously informational only. But one of the things I noticed too was once they were declared brain dead, I finished my charting, and then they had a different chart.
Yes,
right?
they did. They still do. It's done through the EMR now. It used to be a different sheet of paper, but for us, it's still done through the EMR. But again, their orders guide you on how often you need to check everything.
Mm-hmm.
So, are you checking blood sugars every hour? Are you checking CVPs? Because it'd be interesting. Actually, I haven't done one in a while. But now the focus is more on NICOM to determine fluid status as opposed to CVP.
Non-invasive cardiac monitoring.
Right.
For those of you that don't know.
So I'll be curious on how they do that now. But regardless, they're going to decide kind of what tests need to be done. So what are we looking at potentially trying to donate? Are we looking at the heart, the lungs, the liver, the kidneys? So if we're looking at the heart, then they're probably going to get an echocardiogram. And then depending on the echocardiogram, they're definitely going to get cardiac labs, but then they'll do the echocardiogram. Depending on the echocardiogram, we may have to go to the cath lab.
Yeah, because if they're going to donate their heart, you have to check the coronaries, right?
Yeah, absolutely.
And the valves and
Yeah.
Oh, yeah.
So, and it's interesting, a little tidbit I learned from taking a patient to the cath lab is that if they find blockages, depending on the overall health of the patient and age and appearance of the heart, sometimes they'll actually do a bypass. Like when they take the heart, they'll do a bypass before it gets transplanted into the new patient.
Oh my gosh, I did not know that.
Yeah, I didn't know that either until I took him, and I was talking about this. So what do you do? So in that particular case, it was an exclusion. Like they determined based on all that data that this was not going to be a good patient to try a bypass on. But essentially, they'd get a cabbage.
Wow.
Yeah, which I thought, that's crazy. But that's just, and that's just looking
That's
at the
just
heart.
the heart.
Right. So we've talked about blood work. We talked about echo. We've talked about potentially cath lab.
They get a bronchoscopy.
They get a
usually, if
bronchoscopy.
They're going to
so
look at the lungs,
yep.
so they can get the measurement of the lungs.
And I've heard with the lungs, there's not that they're not super picky otherwise, but even more so with the lungs. Because actually, something that's common with a lot of patients that have had a neurological injury and losing consciousness is aspiration pneumonia, and getting gunk down in their lungs
And they're on antibiotics.
and they're on antibiotics. So aren't they pretty particular about if they've had that at all? Then that's kind of like an exclusionary, or is not necessarily.
Not necessarily. It depends on a lot of things, because like Elizabeth said, that they'll put them on antibiotics. So if it's just something that is temporary and kind of easily fixed, if you will.
And I believe the lungs are the most difficult to donate as far as matching recipients and stuff.
You have to have the right size for the chest and
Yeah.
things like that. So
Yeah.
but they do, and then for neuro patients, neurogenic pulmonary edema, so hence the Narcan, so
Yeah.
we'll dry them out a little bit.
Yeah.
And that's why we do a lot of I's and O's too, because if they're fluid overloaded, we're quick to try and diurese those lungs if need be. The lungs also, bronchoscopy is a big thing, so they may take samples during the bronchoscopy, tissue samples as well as sputum samples and things like that. So they look for viruses and bacteria and fungus and things like that.
And the crazy, this is all within just a few hours. Usually.
Yeah.
Oh yeah, that's why
You
you
are
were
working
saying
your tail off.
2 to 1,
yeah.
2 nurses to 1 patient, because 2, essentially you're doing all this to buy time
Yeah.
to get to the OR, essentially, right?
Well, and the people who are potential recipients, those surgeons, they're wanting information. They're wanting to know what this stuff looks like. So what's crazy is things may be looking great for a while, and then the surgeon, one test comes back funky, and then potentially it's crazy, just the ups and downs. Like the surgeons who are in charge of the potential recipient may want other things done.
Yes.
And what's crazy is, like, they're talking to hospitals and other organizations maybe all over the country. You may have a potential recipient who's in Boston, and we're down here in Charlotte. I mean, it is just, the networking is, to me, that's just amazing to me.
Yeah. Yeah, it is, and especially with how time sensitive it is, and some surgeons want to be the one that procures it to put it into their recipient, and of course that so many things have to happen for all of that to occur.
There's a lot of things that have to come into place.
But you are a primary. You are in the role there. I mean, you are the person that's helping manage that patient.
Oh yeah.
I mean, if I do a bad job as the nurse, then I'm impacting the perfusion of those organs. And if I'm not Johnny on the spot, then I can take a potentially viable organ and make it non-viable.
Yeah, for someone who's been notified, hey, we have a potential match, go to the hospital you're supposed to go to, and then they go and they get draped and they get ready to go for surgery and prepped, and then it's like, oh wait, no.
Yeah.
Not that so the stakes can be pretty high. It's not like you're just kicking it. Like
it's intense.
It's pretty intense. And what happens? Let's say, so we're buying time, but what happens if the patient codes, if their heart stops? Because we were saying how if the brain dies, that stuff happens. So what happens if that happens, and has that ever happened to you guys?
Not to me.
I have not had a code.
Thankfully. I know, right? Let's knock on the wood that's here. Sorry.
Sorry, recording. Knock, knock. But so essentially they become a full code, right?
Yep.
Which is kind of
They have to be
perplexing.
resuscitated.
But it's, and without the urgency of a pending cardiac arrest. And hopefully you'll see some signs that is impending, whether it be some sort of
Heart rate change.
rhythm, rate, ectopy, because we're doing all kinds of labs periodically, so we can catch any shifts in electrolytes and we can maintain all that. I mean,
Oh
this
yeah,
is-
because you're checking stuff a lot more frequently
oh
than
yeah.
like someone
There's
else.
labs,
And they're
all the
ordering
time.
labs, and you're not going to wait an hour to draw those labs. Those are
Nope.
stat.
Yeah.
Mm.
You get an order, you do it. Everything.
Yep.
Every medication,
Yep.
every test
Yep.
is not, I'm just waiting. And honestly, like we will call the pharmacy and say,
Yep.
heads up, we have an organ donor here. And so that they almost assign a personal runner, if you will.
Yeah.
So they don't wait. Like that doesn't go into the queue. That the pharmacy queue, it doesn't go in the bottom of the list on the pharmacy queue. It
It's
literally
top
is
priority.
a top priority. So it's an amazing process. But we can keep someone in that phase of care for several days if need be. Now, hopefully we don't. Hopefully we can find matches and things like that fairly quickly. But we can potentially keep them there for days. Now, in the setting of a pending cardiac event, and we start getting those signals, ideally what happens, and again, I have not experienced this, thankfully, hope I never do, but I have asked many times because I'm just that much of a control freak and paranoid, what happens if the heart does stop? And so the response to that has been by about 5 different coordinators, we do chest compressions on the way to the OR. And that's what happens. So at that point in time, they go to the OR so that they can go ahead and do the procurement to get those organs, and then they'll figure everything else later.
Yeah.
So, things like a heart that only has every organ has an amount of time it can kind of be outside the body or not receiving blood flow. It's different. Hearts are not going to last as long as kidneys will, for example.
Right.
So depending on how close they were to finding a recipient can depend on which organs they can then be able to use.
And it's usually, so let's say a patient is potentially is going to donate all of the major organs. The lungs go first. So it's the lung surgeon, it's the cardiac thoracic surgeon. The lungs are all usually taken first.
The last most interesting one that I watched, and I always like to go, I don't get paid for it, by the way, but I like to go to the OR because I find it very fascinating. But the last one that I went, that was a heart and lung donor, they actually kind of took them simultaneously. I mean, they
don't wait. Yeah, they wouldn't wait.
Yeah.
They're not going to say,
But it is crazy the amount of work that they do in the OR to get a direct view of heart and lungs. Like, I remember standing by the CRNA and the surgeon was like, lung up, lung down, hyperinflate, underinflate. Like, and they must have done that 100 times easy. They took blood gases directly from the lung tissue. I mean, it was just crazy, the things that I was seeing. But all to make sure that they're healthy and, the right size and shape. And there's nothing hidden in between the lobes that might be some sort of malignancy. And,
And one of the things that when you guys were talking about this, that if an emergency happens and they have to emergently get down to the OR to get stuff, it's just to kind of think about, this is already awful for the family, but maybe they were looking forward to that point when they could, give him a smooch. And if it goes actually according to plan, they can't really see him again without a ventilator, right?
Right. So they, I have had a few families that stay until they go to the OR, and then they give them that kind of last kiss on the way to the OR.
Yeah.
Most of the families ultimately want to say goodbye before all that starts.
Yeah,
because
they don't want to
the
be around.
prospect of all that work that we're doing is kind of overwhelming.
And just speaking as the nurse, that's easier for me.
Yeah.
And the
not have them
family
around.
support coordinators are so amazing in sort of helping facilitate and kind of help them, because I think they'll be they kind of help stand by them and say, okay, this is time, or they'll be there with the family. I have found.
Yeah,
Mhm.
that's
And
so
they're
helpful to have that.
And I have not seen a code essentially with a donor patient, but most of the time the families have said goodbye.
And so then,
Most of the time.
let's say you've done all this work, you're doing your thing. We've got an OR time, and then you, as the nurse, just send them down to the OR, right?
You go with them.
Mhm.
And that's essentially
The
as
transplant teams are there.
yeah, because that's when your job is done. But then, we're probably speaking to some nurses out there that are on the other side of it, that are going to be the transplant ICU nurses or in the OR, and so we're not familiar with that end of things. We're familiar with the
getting them ready and
getting
getting
them
them
ready.
to the OR.
which would be super interesting to like interview a transplant nurse. And,
That really would.
Mm-hmm.
yeah.
And have you ever watched some of the hospital shows?
Oh, I sob. I cannot watch those right now. Like Boston Med does it really good because they show the whole thing and the aspect of the patient waiting for the lungs or whatever it is, and just that. Because when I saw that, it was emotional for me because I was so familiar with this side of things. So it was so cool to see. We see the sad, awful part, and then that was showed like the really hopeful, like, hey, this is life-changing kind of situation.
Or when you see, you know, the mother who lost their child or their a young adult, and that person's heart went to someone else, and they hear the heartbeat, and there is a big, just that is an emotional side to it, and that's sort of somewhat a little light at the end of a bad tunnel, dark tunnel.
Yeah.
But should we talk about donation after cardiac death?
That I was like kind of feeling like we were rounding that out, but I did want to talk. Is there anything else you want to talk about that before we go into something
Well,
a
I just
little
kind of
different?
wondered, do you think that they would like to hear about the kinds of tests that they do for the various organs? Or,
Oh, I mean, if I don't know those off the top of my head, so that'd be great.
well, I mean, it's going to be patient specific, but like we kind of talked about the heart being that lab work,
Mm-hmm.
echo,
Yes.
cath lab potentially, with the lungs, ABGs. They do an O2 challenge, so basically they want to kind of see how much oxygen the lungs will hold on to. To make sure that they stay well oxygenated, because if they kind of fail the O2 challenge, then they wouldn't be a good potential donor for lungs. But the bronchoscopy is really important. But what becomes part of that is the suctioning for the patient. So remember, this patient's brain dead. They don't cough when you
Right.
suction. So when you suction a patient, unless something is sitting right there where the suction catheter goes, you're not going to get anything out. So turning the patient and suctioning the patient regularly is incredibly important. This isn't something that you can just be like, they're brain dead, I don't have to worry about skin. Well, it's not about their skin, it's about their lungs.
Their skin's an organ, too.
It is. That's
Yes,
true. Because
that's
if they
true.
get pressure sore, then they can't donate that portion of their skin. But the turning at that point then becomes more about the lungs and trying to get any kind of secretions that have built up to move so that we can get them out and maintain that good oxygenation in the tissue. The liver a lot is related to lab work, and then they do an ultrasound of the liver. Sometimes they may do like an ultrasound guided biopsy or something
Really?
like that. But it kind of depends on the trend of the lab work and things. And remember, with the kidneys and with the liver, sometimes we can give medications or blood products and help kind of restore the health. Like if it's, a shocky liver that kind of had a temporary
Injury.
lack of blood flow that we can then perfuse a little better, then, the enzymes can start to improve. For the kidneys, it's lab work, of course. It's all about the right amount of fluid.
Oh, yeah. So that's, again, the INO.
Right. And it's they're all about perfusion. So if you don't maintain a good blood pressure, then they're not going to get the good blood flow that they need. And again, they can do ultrasounds or things like that. But a lot of it, too, is we get them down to the OR, and then in the OR, we can do everything non-invasively, essentially non-invasively that we can before they go to the OR. But in the end, we can think everything is perfect with these organs. And then they get there, they open up the body cavity and find something that we didn't see on ultrasound. And so actual inspection by the transplant team of the organs is incredibly important too. So I have also seen it where the patients go down to the OR, and then they get a look at the organs and find some sort of malignancy that they had no idea was there. And, then that kind of, that excludes them as being able to be a donor. And in that case, I always feel bad for the family, because they went through all that stress of going through the consent process and making the decision, to give those gifts to somebody else is, it's an incredibly noble thing and an incredibly unselfish thing to do in that dire time, to get that disappointment of not being able to be the donor after all. So that always breaks my heart.
That reminds me of actually Boston Med. I was watching one of those episodes, and everything looked great, and then they get into the OR and they find a spot that they were like, and I don't remember what organ it was, but just talk about how quickly they get things done. They took a specimen or took a thing and immediately had a pathologist read it, like immediately, and then decided. They're not waiting 4 days. They're having there's someone on call that hey, look at this immediately, and then they said, okay, no, this is not concerning. Go ahead and this is okay.
Yeah,
which was amazing to see how fast and how prioritized and how I thought that was amazing.
we can't say enough how much time is of the essence for these patients. So they become a priority for everybody who's potentially involved in it. They consult
many lives.
They consult pulmonology. They consult cardiology. They'll consult a GI doctor. I mean, they'll consult other physicians to help make the preliminary findings, or make preliminary recommendations on whether something is viable or not. And think about the pressure that puts those doctors under too. A cardiologist is out there saying, I think that this heart's a potential candidate. And nobody wants to say that yes, I think this is a go, and then find out later on that it wasn't.
Right.
Right. But it's an amazing process, and it's something that I personally am very passionate about. So I kind of have to shut myself emotionally off from the reality, the personal side of things at that point.
Yeah, it becomes kind of business-like almost.
It really does, and it's the self-preservation for me, honestly. But I do focus on the good as far as think about the recipient on the other end of that.
And how if someone does all of it, all as much as they can, isn't it 7 people that if you donate everything?
I think it's more.
Actually, I was going to say the same. I think it's more.
I think it's
because I guess tissue and eye too, if those go to however many people. So
your lungs could potentially go to more than one recipient. Obviously, the heart can't. The liver, I don't. The liver is an organ that's unique because it can regenerate itself.
Yeah.
So you can get a partial liver donation and it'll regenerate itself. So I don't know if they typically separate the lobes to place that. I think it usually goes as a whole organ, but I don't know enough to swear to that. So
just been watching too many Will Smith movies. Katie,
7 pounds. No, I watched that movie once. I'm never watching it again.
I don't even know that movie. It doesn't sound like I want to watch it.
Don't watch it. But
intestine, pancreas.
Yeah.
They do that now.
Yep.
So now that I kind of want to move into DCD. So for those of you that have never heard that before, it's donation after cardiac death. Let's define that first of all, and kind of talk about how that management looks a little different than what we just talked about. So I want you guys to kind of compartmentalize what we just talked about. And now we're going to talk about something that is in the same realm, but it's actually different. So we're at that point where we have a patient that is almost brain dead.
Or has had such a neurological insult that although they may never meet brain death criteria, the family is aware that this patient will not have essentially any quality of life.
Does that make sense?
I mean, it's like a persistent vegetative state. So the family is potentially, well, in this case, requesting withdrawal of care. But the patient is not brain dead.
Patient's not brain dead.
So that last episode where we talked about all these things are negative, all the reflexes are not there. Well, maybe this patient has a couple of them. Maybe they don't have a cough, gag, corneal, but their pupils are reacting.
Maybe they take a breath.
I had a patient literally at the end of a 5-minute apnea test initiate a breath. And we repeated this test for multiple days and the same result.
Wow.
So they literally, that last little bit of brainstem function was all they had left.
Wow. So that would not meet the brain death criteria where you can say, declare the person dead, because they're not.
Right.
So what do you do? What do you do when you, in that situation where you have a patient who has no maybe awareness, some may, but no, maybe not have awareness or not know what's going on, no pain, no, like and maybe family knows they want to be an organ donor, and
also the prospect of like they're on life support and we have enough evidence or we have a lot of thought as to if we withdraw life support, they will pass on their own within an hour in most facilities. So if we took them off the ventilator, they would essentially, their heart would stop within an hour.
Our best educated guess.
Yeah, best educated guess.
Because you can't say that for sure.
There's no guarantee.
So we're talking about this instance where, okay, we've got this patient in this situation, and we're pretty confident that if we took them off the ventilator that they'd have a cardiac arrest within an hour. And we want it, and the family, and the patient, family, they want to donate their organs.
And there's an age limit. I
think it's 55. I think.
This
or younger.
It's much more challenging, I would say, to do that, to donate after. So it's called donation after cardiac death. So remember, not brain death, but cardiac death. So they're still donating their organs, but we've got to let them pass first.
Yeah.
And there's only certain organs that can be donated.
Yeah, and because we have to allow that cardiac death to occur, and during that time, those organs are not most likely being perfused appropriately. We were talking about how big of a deal timing is, and continuing to perfuse the organs.
Because I was going to say, in brain death, we can maintain that organ perfusion by leaving them on Levophed or whatever vasoactive medications they're on. So it's much easier to maintain perfusion in that case. In this case, we have to stop all that. Because we essentially want the heart to stop within an hour. So if we keep augmenting their blood pressure, it won't. So we stop all of that stuff. And they're essentially on event withdrawal.
On event, yeah.
No, they extubate, so they're not on.
We extubate. We do a lot of, so in that process, in that workup, we do a lot of lab work. They may have some testing, not as much testing done, because it's the heart and lungs cannot be donated to another human with DCD. It's usually the kidneys and the liver tissues, but it's not the heart and lungs. They're not eligible.
Yeah, because the heart has to go through cardiac death, right?
Right.
So why would you be able to donate that?
Yeah, the lungs, yeah.
And so this is like a very specific situation, but it's important to know kind of the difference, because I've actually had a family member before say, hey, and she actually did have a medical background. She's like, so I know we're kind of at the point where she's not progressing to brain death, and I know that's at the point when, you look at organ donation, but is there any option where, she has no quality of life, and she wanted to be an organ donor.
Mm-hmm.
Donor. I need more coffee. But what do we do? Is there an option? I want to know, because I know this was important to her. And then that opened the door for me, like, oh, I'll have you talk to the organ procurement. And so when we're talking about this situation where we extubate, we're not doing this at the bedside. This is something that's done typically, you would, right? In the OR in most facilities. Again, we're generalizing because we're we've had our experience, and that's what we're familiar with. But it may be done differently somewhere else. But I can't imagine it was be done outside the OR.
So when they have the recipients of the potential organs, the transplant team has flown in, then what you do is, I've worked at facilities where they're taken to a pre-op holding suite. Some facilities they're taken to the OR. Sometimes they're in the unit. You treat them as you would a palliative care patient in the hospice patient, in the sense that you're giving them comfort medications to keep them comfortable. So you prepare the patient in that sort of way. So whether it's a PCA or it's a morphine infusion, you set it up and you're going to treat them as such. And you have medications on board to treat if they have trouble with secretions, if they have trouble, you're going to keep them as comfortable as possible, and you're going to extubate them. And essentially the transplant team is here, they're ready. So at that time of death, when the patient's heart has stopped, the family says goodbye, and you are either in the OR or you're immediately taking them to the OR right away.
And they have a time limit. They have an hour.
They have an hour.
1 hour. Because if you think about, if you just let them take as long as they need to pass, those organs are not getting that oxygen.
Well, if they're still alive after an hour, then they're taken to usually a hospice unit or a private room so they can be with the family.
Yeah, so you have like this backup ready to go kind of thing. So that, yeah.
But you have to have them ready to go immediately to the OR. There's like very little time. You can't sit around after the heart has stopped.
Right.
And the families are prepared for this. You have a family support coordinator who is going to prepare them and tell them that once the heart is stopped, you really have to say goodbye right then and there because we've got to get to the OR because those organs are not being perfused.
Right. And we need them to be perfused to successfully
yeah.
give them to somebody else.
And the families
yeah.
are aware.
So and at that point they get reintubated and they get put on drips and they get all those things done
so fast.
Actually, I lie. I take all that
No,
back.
because they're dead.
They're dead.
They're no longer alive.
They it's literally almost the family goes out one door and the surgical team comes in the other.
Yeah.
Like that.
It's so fast.
It
Yeah.
is so fast.
And depending upon, it might even be like they might even be standing behind a drape, the surgical team ready to go. I mean, because it
I have
has to
heard
be
that,
so fast. So, yeah. I mean, those are the two kind of.
And you're there to keep the patient comfortable.
But this is something that is also not available in every state, and it's fairly new in North Carolina.
Okay.
So it's not even something that is an option everywhere across the board. But and because it is, like Elizabeth said, such a moral and ethical dilemma of what do we do in this case that my family member isn't brain dead, but I know they wouldn't want to be prolonged in this state. And they wanted to have the option of donation or things like that. So
it's a very touchy subject.
it is.
Understandably so. And so with the show notes of this episode, I'm going to try and find as many resources that I can related to both organ procurement and donation, as well as the donation after cardiac death, because it is challenging to really understand it yourself and then also communicate it in a sensitive way. So these are big topics, guys.
And utilize your support. Family support with OPO is essential. You have to have them there. That's what they're trained to do, is to be and you kind of and you're being sensitive too, but they're professionals at this. This is what they do every day.
Yeah, and
they stay with the patient. I mean, I had a coordinator one time who lived very far away, and he stayed days with this one particular family because he had established a rapport with them. He worked with them, and in the end, we had, the patient ended up being a donor, and we had another light at the end of the tunnel, so to speak. And I give a lot of props to him because he did such a phenomenal job.
Well, I think that concludes our kind of brain death organ procurement explanation from the neuro ICU nurse perspective. So I'll put up some additional like resources, but check out your state and your region's organ procurement organization. Donate Life is ours, right? No, Life Share of the Carolinas is in North Carolina. Is the Charlotte one?
It's Charlotte. There's also Carolina Donor Services.
Yeah, and so it'd be great to get to know that in your area, especially if you're going to be in this position where you're working ICU, because it doesn't just happen in the neuro ICU. Depending upon the size of your facility and location, it could be in just a medical surgical ICU, cardiac ICU with anoxic brain injury and all that. So thank you guys so much for listening, and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got